Good evening, everyone. I'll be discussing on a case of combined retinal vein and artery occlusion associated with antiphospholipid syndrome. A 22-year-old woman, 6 days postpartum, presented with a 4 days history of sudden onset defective vision in her left eye. There was a positive history of transient episodes of visual obscuration of 2 to 4 episodes during her pregnancy. There was no history of floaters, flashes, redness, eye pain, visual field defect, and trauma. She was a known case of antiphospholipid syndrome and antinuclear antibody positivity with a history of eclampsia and 3 prior miscarriages. Recently, the patient delivered a preterm baby 6 days ago who was unfortunately passed away within 24 hours. A systemic history, APLA syndrome, hypertension, personal history, mixed diet, socioeconomic history, lower middle class. On general examination, pallor was present, temperature was normal, her blood pressure was 150-100 millimeter mercury. Systemic examination was normal. On day 1 ocular examination, her burst charactered visual acuity on right eye was 6/6 partial and on left eye nil light perception. Intraocular pressure on right eye was 14 milligram of mercury and on left eye 16 milligram of mercury. The anterior segment on the right eye was normal. On left eye on pupillary examination, relative afferent pupillary defect of grade 3 was noted and on corneal reflex exotropia 15 degree was noted. Otherwise, the anterior segment of left eye was unremarkable. The fundus examination of left eye showed the media was clear, optic disc looked pale. The veins were dilated and tortuous, and the arteries were attenuated. In background retina, flame-shaped hemorrhages were noted in all quadrants. The foveal reflex was absent. The fundus examination of right eye shows the media was clear, optic disc was normal, the veins were mildly dilated and tortuous, and there were few focal areas of infarcts temporal to the macula. With these clinical features, optical coherence tomography was done on both eye. The left eye OCT shows hyperintensity foci and thickening of the inner retina, which was suggestive of acute artery occlusion, and the macular edema was suggestive of vein occlusion. There was also hypointensity of the outer retina. The OCT of the right eye shows was normal. The patient was diagnosed as left eye combined retinal vascular occlusion. On further evaluation, the MRI brain revealed lacunar infarcts in bilateral coronary radiata and periventricular regions suggestive of vasculitis, and the ESR was high, and other conditions like HIV, syphilis, and tuberculosis were ruled out. On treatment course, in the initial management of intravenous methylprednisolone of 1 gram BD for 3 days was started. Intramuscular injection of dexamethasone was given. Posterior subtenon injection of Kenocort were given. A referral letter was given to a rheumatologist for systemic disease management. And the patient was started on acetone 2 mg and hydroxychloroquine 200 mg. On 1 month follow-up, no visual improvement in the left eye was noted. Left eye fundus showed macular scar with residual hemorrhages in all quadrants. The patient continued rheumatologist-directed treatment and was advised to maintain regular follow-ups with the rheumatologist. On 3-month follow-up, no visual improvement in the left eye. Fundus showed subhyaloid hemorrhage and vitreous hemorrhage with inferior tractional retinal detachment. For left eye, pars plana vitrectomy with maximum photocoagulation was performed under nil visual prognosis to prevent neovascular glaucoma. The patient is under regular follow-up with her rheumatologist and is on systemic therapy. She has been advised periodic review to monitor the progression of central retinal vein occlusion in the other eye. Coming to the discussion, combined retinal vascular occlusion represents a rare yet significant clinical entity that involves simultaneous or sequential occlusion of arteries and veins, frequently associated with systemic comorbidities such as hypertension, diabetes mellitus, and hypercoagulable states, highlighting its multifactorial etiology. The hypercoagulable state in APLA syndrome results in ischemia, edema, and significant retinal damage. This case highlights a rare and severe ocular complication of APLA syndrome compounded by systemic vasculitis leading to combined vascular occlusion and irreversible vision loss. Prompt diagnosis, systemic control, and aggressive ocular management were critical in minimizing further complications, particularly in the fellow eye. Conclusion. Our case highlights a rare disease with poor visual outcome, emphasizing early diagnosis and a multidisciplinary approach, aiding the physicians in similar cases. To the best of my knowledge, only 3 cases were reported till now. These are my references. Thank you.
I just have one question. You said on day 1 of examination itself, your patient had 15 degrees of exotropia.
Yes.
How do you explain that? Because when I look, it looks like pallid disc. I agree, the vessels are totally occluded. But how do you explain the exotropia?
When the patient was presented, there were minimal 15 degree of exotropia.
How do you explain that exotropia? Because there has to be a reason for that exotropia, whether the vision was already compromised before this event. How do you explain it?
Patient was complaining only of sudden defective loss during that time only.
But that's what something which is probably important, that as a clinician we need to see that. And the second thing is, somehow maybe it happens in places, but usually when the eye has nil visual prognosis or NPLI, we usually do not do pars plana vitrectomy and surgeries like that. So that is another thing that I
Also, media was pretty clear for the laser to have been done in case to prevent NVG for NVG. I know.
What was the intraocular pressure in that case?
So pre-op.
What was the intraocular pressure? Because this is very much important. A lot of vascular occlusion, so might develop neovascular glaucoma.
The patient did not develop neovascular glaucoma till now, sir. On
Did you
the
do
regular
gonioscopy?
yes, sir. There was no NVI and NVA. Thank you.
Thank you, Dr. Arani.